الو الو. بسم الله. تيست. تيست مايك. الو. بسم الله والصلاة والسلام على رسول الله صلى الله عليه وسلم. تيست. 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 الو. تيست. تيست مايك. تيست. الو الو. تيست. تيست مايك. تيست. انت كده لايف صح؟ تيست. تيست. تيست مايك.
بسم الله الرحمن الرحيم. ده نفس القصة. بسم الله الرحمن الرحيم. يلا ظبط معايا تيست وانا هظبط معاك الصوت من هناك. خلاص يعني دول لازم يبقوا كده عشان يبقى قريب.
بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. بسم الله. يلا والله يلا حيا شلونك؟
بسم الله الرحمن الرحيم. بسم الله. بسم الله.
احنا نبغى شرب يعني نبديها 8:30 باقي 4 دقائق. اي خلاص اعرض. بسم الله. بسم الله الرحمن الرحيم. Good morning everyone. For day 2 we will continue with an equally comprehensive agenda. Session will explore obesity intervention, lipid management and chronic pelvic pain, lifestyle medicine, hypertension and dermatology, smoking cessation and common primary health care conditions such as asthma, herpes zoster, migraine. The day also highlights the importance of mental health and integrative care in modern family medicine. We are proud to host this event with the support of our strategic and organizer Bertrand, and we extend our heartfelt gratitude to all speakers, attendees, and all contributors who made this conference possible. We begin the day with Dr. Khalid Sidhan, Assistant Professor and Family and Obesity Medicine at King Saud University. So let's welcome Dr. Khalid Sidhan.
السلام عليكم. السلام عليكم ورحمة الله وبركاته. صباح الخير. والله سعيد إني أكون موجود معكم اليوم. First of all, I would like to thank the conference committee for inviting me for this topic. So I'm Khalid Sadhan, Assistant Professor in Family and Obesity Medicine in King Saud University in Riyadh. So today I will talk about the obesity in general. I will focus more about the surgical and the medical intervention and which way to go. And I will focus more, to be honest, in the medical part about the medication, especially the incretin-based therapy. So, Bismillah. So I don't have any conflict of interest. So as a content, we'll start with the impact of obesity in terms of prevalence, especially local prevalence, and pharmacotherapy of obesity. Look at the past and current pharmacotherapy of obesity, and beyond weight loss, what's the evidence in the cardiovascular, what's the health outcome, and let's say obstructive sleep apnea and others. And I will briefly talk about the safety of GLP-1 agonist, and we will review the surgical intervention, and I will conclude and then a takeaway message. So to start with, the prevalence of obesity in Saudi Arabia in 2024, according to General Authority of Statistics, is 23%, and the overweight it's reaching 40%. So we are talking about endemic and pandemic disease. So we are talking about almost more than 50% of our community suffering from that. So as a health risks and associated with obesity, it's well known that obesity carry more than 200 complications, like type 2 diabetes, heart, cardiovascular, cancer, arthritis, urinary incontinence, etc. So if we are talking about the complications, we are talking about then we'll talk about the effect of weight loss on these complications. So just imagine that losing less than 5% will have meaningful change in the hypertension and hyperglycemia. And when we increase with these numbers, these complications will resolve. So for example, if we lose more than 50%, so even we can reach to type 2 diabetes remission, and cardiovascular mortality will decrease, and heart failure preserved ejection fraction especially will improve much. So if we look to the history, we are always thinking about obesity as a surgical intervention or lifestyle. So the pharmacotherapy in the last, I would say, 10 years really developed. So if we take a look at the lifestyle, most of the evidence talking about the lifestyle modification as it will result in between 5 to 8% of weight loss, and these numbers with a gastric band or gastric sleeve or gastric bypass usually exceeding 20%. So we have in the middle we have really area that it's not really covered. So nowadays we have a lot of pharmacotherapy which lead to double digit weight loss, and we will talk about it inshallah. So as an approach, I really like one of the approaches that I review it in the Saudi guidelines, which I will show you today. So it was a Saudi guidelines which was published in 2022, talking about the obesity and how can we approach obesity in the family medicine and internal medicine clinics. So we start always with assessment of adults, and we evaluate the obesity by measuring the BMI, by measuring the waist circumference. Then we will categorize our patients either that they are overweight or obese, and according to that we will build our assessment. Then we will move to assess the patient's readiness for change. So if the patient is ready for change, we will set a goal of weight loss. So if the BMI between 25 and 35, just to make sure that to have smart goal, let's say between 5 to 10%, and in a, let's say, a 6 month period. So if we are talking about the changes, what is these changes? The lifestyle modification, we are talking about the dietetic support, nutritional therapy, physical therapy, and also if there is a need of cognitive therapy or goal setting with a physician. So after 3 to 6 months, we will re-evaluate our patients. If he is reaching the goal, that's fine. We will continue the same for another 3 months. If not, we will refer to specialist service, I would say, or offering pharmacotherapy on bariatric surgery, and this is will be a personal decision rather than either direction by a physician. So pharmacotherapy, we are usually started with a BMI more than 30, and bariatric surgery of the BMI more than 30, or between 35 to 39 with a comorbidity. So, okay, we'll talk about the pharmacotherapy of obesity. Just to take a look on the history. So just imagine that the anti-obesity medication started almost 100 years back with the multiple medications and trial, which is discontinued year by year because of the side effects, until the beginning, I would say, of the last decade, which new medications appear on the surface, like naltrexone, liraglutide, semaglutide, tirzepatide, which become now available on the surface, which now increase the landscape for obesity medication. So I will start first to talk about a little bit about the scale trial with the liraglutide, 3 milligram, and the change in the body weight. So if we take a look on liraglutide at scale obesity trial, we will find that in the week 56 of the trial, the intervention group, which is the liraglutide, reached almost 9.2 weight loss in compared to 3.5 in the placebo group. This is a liraglutide. And if we go further for the step 5, semaglutide 2.4 milligram for the weight loss, which was, the participant was almost 300, we are talking about weight loss reaching 16%. So now we are moving from single digit to double digit with a semaglutide. So this is step 5. So also if we continue the tirzepatide and surmount one trial, which include almost more than 2,000 patients, we can see here even there is dose-dependent weight loss, which is reaching 21% on the maximum dose. On the maximum dose, sorry, you can hear me now? And also, if we take a further look to the categorical weight loss, we will find that almost third of our patients on the maximum dose lost more than 25% with the tirzepatide. So it's almost equal to the bariatric surgery weight loss. So just to highlight something which is really important about the weight regain after GLP-1. So there was a trial of semaglutide 2.4. It was a step 1 trial extension when they extend the trial and they stop the medication, and they found that there is a significant weight regain of the patient. So for now, we say this medication is really effective when we use it, but still the question about when we stop it, how to stop it. But for now, I would say it's really important to counsel your patients about this, and for now, it's a medication most likely for life. And we will find similar results with tirzepatide on SURMOUNT-4 trial, almost the same. It was 36 weeks open label tirzepatide, 10 or 15 milligram weekly. Then they randomized the patients to 2 groups, either they continue on tirzepatide or a placebo, and they found the same significant weight regain. So it's really important to highlight this to our patients. So what's beyond weight loss? So obesity, as we said, there is a lot of complications with obesity. So it's not really only a weight issue. So there is a lot of complications with that. So what's happened with that? So let's take a look to one of the landmark trials, SELECT trial, which was a trial of almost 17,000 patients with a secondary prevention of cardiovascular. The patients was more than 45 with a BMI more than 27 with established cardiovascular disease. So they found with that there is almost 20% relative risk reduction on these patients who was in semaglutide. And which is really interesting that even if you can see here in the graph that the separation started from the first few weeks, so maybe there's something about the inflammation and inflammatory markers. We are not sure, but we found it to be useful for such patients. So now, even if some guidelines, they include it as one of the medications for secondary prevention on this group. So more of that. So they did a step heart failure preserved ejection fraction of semaglutide also, which was in obese patients without diabetes, which shows significant improvement in City cardiomyopathy questionnaire, which is the questionnaire used to evaluate heart failure patients. So there was significant reduction in the heart failure related symptoms and physical limitation. So also in the SURMOUNT obstructive sleep apnea, which was published last year, which show magnificent results in decreasing the apnea-hypopnea index. It was 52-week trial, phase 3. They include patients moderate to severe obstructive sleep apnea, either newly diagnosed or known to have obstructive sleep apnea. And most of them, or sorry, all of them, the BMI was more than 30, and the primary endpoint, the change of an apnea-hypopnea index, which was positive results with a significant reduction in the index. So, adverse event of GLP-1, we always get these questions. So, what's about the safety? So we will talk in general about the general side effects, which was published in the first semaglutide step 1 trial. So it's really known that the GI side effects is really significant with these medications. So, but most of them will improve with time, except a little bit. The evidence showed that constipation can stay longer. So we need to be alert of that. So yes. So in general, you know, the side effects, the pancreatitis and thyroid cancer, it was reviewed a lot and more than ever, and a lot of evidence. So and research was involved in that. So I'll talk a little bit about that. So there was a landmark trial which showed that adverse event associated with the GLP-1 agonist of weight loss, and they include the liraglutide and semaglutide. It was a random sample of 16 million patients between 2006 and 2020, and almost the number of patients was at the end almost 6,000 or 7,000. And they compare the GLP-1 with the patients who used naltrexone propropion, and the results was show that there is increased risk of pancreatitis, bowel obstruction, as gastroparesis with GLP-1 users, and there was increased but not statistically significant percent of biliary disease. So again, as we know that this medication can lead to increased risk of these complications. So the common question, what's about cancer? What's the evidence about cancer? Is it increasing the evidence of cancer? So there was a study, systematic review was published in 2023 in July. It was data from 37 studies of almost 50,000 patients, which show there is no increase in cancer or pancreatic cancer or thyroid cancer or any cancer with that. And another study, which was published in 2024, was in diabetic patients to assess the GLP-1 receptors agonist in 13 obesity-associated cancers. So they compared to insulin users and to metformin, and when they compared to insulin users, they found that GLP-1 associated with lower risk of 10 out of 13 cancer. Similar result with the metformin, but just to highlight something, that there was a signal of increase of kidney cancer with a GLP-1 user. So the explanation is not really understood in the evidence, but we need to be cautious with that. So also there was a really popular study which is about semaglutide and the risk of non-arteritic anterior ischemic optic neuropathy, which lead to blindness. So it was a retrospective cohort study assessing the association between the semaglutide users and development of ischemic optic neuropathy in type 2 and obese patients. So results show higher risk of the disease in the semaglutide group. So just to highlight some limitation of the study, it was a single center study, retrospective study with high risk of selection bias. So really it wasn't designed to show the cause relation between the disease and between the semaglutide. So that also the confounders like the smoking or the confounders that increase the risk of anti-ischemic optic neuropathy wasn't eliminated. So the confounder factors was there. So, sorry. So next, what's the challenges? So if we take a look to the challenges just before that, just imagine that in US there was a paper published in last June 2024 that showed that almost 20% of US citizens use GLP-1 before. So 1 out of 8 in US, they tried GLP-1 before. So this will take us to the trend of the use of the product in US, and I think we have a similar numbers here, but unfortunately I'm not aware if there is any data about that. But if we take a look to the prescriptions numbers between before 2021, it was less than 6,000 per year. But if we take a look to the evidence about between 2021 and 2023, we'll find there is 2,000% increase in the prescription of GLP-1. So this is another challenge that the medication. The medication availability and the counter for our patients, and it's really worldwide issue. So yes, and there was really interesting study talking about the real world resistance and adherence of GLP-1. So the adherence and the resistance is another challenge for us as a physician when we are dealing with our patients. So just imagine that resistance was almost 46% only in the first 6 months, and this number also dropped in the first year to 31%, and the highest resistance rate in a 1 year was with semaglutide, and the lowest was liraglutide. So it's really interesting to see these numbers. So we need to make sure that we educate our patients about the importance of adherence and resistance in these medications to reach the goal. So I'll just quickly review the bariatric surgery. So before that, I would say there is more than 10 or more surgeries for bariatric surgery, but today I will discuss the most common three. So the first, the sleeve gastrectomy, gastric sleeve. It's really common. Usually in this type of surgery, the method of weight loss, as you know, is restrictive, and we expect almost 60 to 70% of weight loss with these medications. And there is some contraindication and acute and chronic complications with these surgeries as any other surgery, but in general we consider it a safe surgery. So the adjustable gastric band was used a lot before. Nowadays it's not really common. The method of weight loss is almost the same. It's a restrictive pattern. The expected weight loss between 40 and 50%, can be more, can be less, depending on the patient. We need to make sure that the patients do not any contraindication of that or not go through it. But as any surgery, there is a possibility of acute complications and chronic complication. What's significant in the gastric band that the risk of reoperation is really high. So Roux-en-Y gastric bypass, or the gold standard, the method of weight loss is restrictive and malabsorptive. So we expect 70 to 80% after 2 years. And in terms of safety, it's really safe surgery. Usually the patients will stay between 2 to 4 days in hospital with some contraindications as any other surgeries. But we need to make sure that the patients who had gastric bypass, they're at higher risk of developing malabsorption. So there was really a nice study which was in 2014. It was a study to assess the 5-year, they did 5-year follow-up for patients with type 2 and with a BMI between 27 and 43, and they put them in 3 different groups, either gastric bypass, gastric sleeve, with a medical intervention or medical intervention alone. And you can see here clearly that the hemoglobin A1C is really much better and much controlled after 5 years in the intervention group, either with a gastric sleeve or gastric bypass, and also the same with the weight, which is really expected results, but just to mention that. So this is really a nice table from the Canadian guideline. So if we just take a look about the numbers and the expected total weight loss of each surgery, as we said, if we look to the sleeve gastrectomy as well, what's here, it's almost reach 25%, and it's more on the gastric bypass, which is really important, the resolution rate of type 2 diabetes. So that's why in patients whose type 2 diabetes, and he do not have any contraindication, the gastric bypass will be the surgery of choice for him. So just to have a summary, I know I talked a lot, sorry, but just to summarize what we mentioned. So current medical therapies for obesity have bridged the gap between the lifestyle and bariatric surgery. With the new DO and triple gut hormone agonists show promising results for future drug pipelines, so we expect a lot of medications to be appear in the next few years. So multidisciplinary team importance, and it's really important to highlight that the multidisciplinary team importance and discussion of the surgery type and medical therapy is really a cornerstone in managing patients living with obesity. So let the patient choose their way and just show them the map. It's really effective method to reach the best results. So difficulty in obesity care likely to continue for several years, unfortunately, but we expect that the introduction of the oral and cost-affordable pharmacotherapy may reduce this in the future. So really thank you. Thank you. If you have any question, I will be happy to answer.
Next, we welcome Dr. Salih Al-Harbi, Family Medicine Consultant, who will present advanced and best practice in lipid management. Please welcome Dr. Salih Al-Harbi.
Assalamu alaikum. Good morning for all. I'm really happy to be among of you today, and I would like to thank the organizing committee for inviting me to be with you today. What I will talk about today is dyslipidemia, and it's good to start about dyslipidemia after I talk about obesity, and thank you, Dr. Khalid, for shedding the light about obesity. So what we will go through is advances and best practice in lipid management. What we will go through, identify the risk factor for dyslipidemia and when to screen for dyslipidemia, And the second issue, to translate that confusing target into action, apply evidence regarding the combination therapy and when to go beyond the statin. And adapt these to special population like diabetes, CKD, etc. So, despite the progress in management and medical care, ASVD is still the global risk or the global cause of death, and all the guidelines, international, agree that LDL is the target. It is the cause of atherosclerosis. It's not an association, it's a cause and effect relationship. But they will differ in the which tool to utilize, which threshold, and which type of combination to achieve that target. What about the prevalence of dyslipidemia in our country? I can point, 3 point. فين كبوينتر كذا على السلايد. هذا قدام طيب, what about the prevalence of dyslipidemia in Saudi Arabia? In the national survey, imagine that over just 6 years, the prevalence jumped from 28% to 42%. And elderly more at risk of having dyslipidemia. There is no gender difference, male and female both affected. And if you look to the graph in the down, the orange is 2013 and the red one is 2019. There is increase in the prevalence and it's common in all age group, including children and adolescents. So the message, dyslipidemia is not male predominant, it affects both gender equally. What about ASVD burden? We are a growing young population. The majority of Saudi Arabia population is below 65. And the number 1 killer is ischemic heart disease followed by stroke. So overall it's ASVD. The age-adjusted mortality or death from ASVD is decreasing due to improvement in care and in growing population, but the chance or the overall prevalence is still high to have ASVD, either ischemic heart disease or stroke. What about hypertension? Again, based on national survey, there is improvement in prevalence of hypertension, but still, majority are borderline, those who are treated and controlled, and we have a great percentage of undiagnosed patients with hypertension. If we look here to the graph, the majority are undiagnosed or uncontrolled, and there is a great percentage of people or person or patient in the borderline hypertensive or pre-hypertensive. And we know that the pre-hypertensive, usually they are obese, they have metabolic syndrome, they have atherogenic lipid, so they are growing with risk. What again about obesity? I know Dr. Khalid covered it, but just to highlight it because it is the gateway to dyslipidemia, there is improvement in prevalence and decrease in the number, but the alarming number is that 36% of young population of children and adolescents are either overweight or obese. What about diabetes? It's linked to obesity, and in 1982 the prevalence of diabetes was only 2% and something, and now it is 24%, and it is projected to be 25% in 2045. So 1 out of 4 will be diabetic. So it's like the new normal of our population to have diabetes. So this is regarding the prevalence. We have high prevalence of dyslipidemia. obesity, even young children and adolescents. We have a great percentage of borderline hypertensive and those who are treated uncontrolled. But what about the lipid? What we focus on? LDL relationship to atherosclerosis is not an association. It's proven to be a cause of atherosclerosis, proven by multiple types of study. So if each 1 millimole reduction in LDL reduce the relative risk by 25%. So the message, start early, aggressively, escalate to non-statin when needed. So, is it only LDL? No. If we look to the table here, and I wish I can point, but I cannot. If we look to the table here, it visualized different lipoprotein. All are atherogenic except the chylomicron and the HDL, which we know for a fact. The chylomicron is not atherogenic because it mainly carries triglyceride and it does not contain apoprotein B. All others are atherogenic. VLDL, IDL, LDL, and the new marker, the lipoprotein little a, which is atherogenic and linked to premature heart disease, linked to familial causes, familial hypercholesteremia, and usually it is static, tested once in lifetime, and unfortunately is not responsive to statin. So ApoB lipoprotein quantifies the atherogenic lipoprotein. The ApoB is measuring the number of particles. The non-HDL also is helpful because it carries all the atherogenic dyslipidemia or lipoprotein. The non-HDL is the total cholesterol minus the HDL. So it's not only LDL. Think of ApoB, think of non-HDL cholesterol, think of lipoprotein little a, which is more atherogenic than just LDL. And especially when there is hypertriglyceridemia and diabetic, when the LDL might be misleading. So, what about hypertriglyceridemia? Is it only, when we think of high TG, we think immediately of pancreatitis. And that's true. The very severe increase in triglyceride is linked to pancreatitis, especially when it is above 500 and higher. But the milder increase in triglyceride is also a risk factor for ASVD because mainly it's carried by VLDL. So the next question, what about screening? What about the risk tool to use? So overall, all the guidelines agree that the age to start screening is 40 for male and female. And to start earlier when the patient has risk factors. Regarding our guidelines, there is Saudi dyslipidemia guidelines, encourage the same and screen earlier when there is a risk factor. But we already established that we have a great prevalence of obesity, diabetes, dyslipidemia. So start earlier when there is a risk factor. What about a global risk assessment? When to use it and how to use it. Let's agree that those who has established atherosclerotic cardiovascular disease, you don't need to calculate their risk. They already had the complication. And for patient who has high risk, like diabetic, familial, they also at high risk. So you don't need to calculate the risk. So the global risk or the total risk is assessing the chance that a patient or a person will develop cardiovascular disease or ASVD in 10 years. Because it combines all the risk together to give you the chance or the percentage or the number that the person will develop this complication. What is the rationale behind the global risk? The rationale that the risk factor is cumulative, interactive, multiplicative, synergetic, and name it. All modest elevation of sum of risk factor might give you a very high risk. So don't think of number, think of risk. Link the target to the risk, link the treatment to the risk of the patient of having complication. And the total risk can help you to not to overestimate the risk, not to overtreat patient who has low risk, okay, and not to undertreat those who have high risk. So you tailor the treatment to the patient risk. So what about age? What if a patient or a person is 45 years? Can you use the same calculator if he's 75 years old? The age make a difference. That's why the ACC, the European guidelines, adopted the score 2 for young population and the score OB, older person, for older person. So the score 2 is age specific, age and according to the region. So for those who above 70, use score OB, older person. For those from 50 to 70, score 2. For those who's younger, consider lifetime risk, because the risk score might be misleading. What about يطلع برا المونيتور بس على الشاشة لا حصلته. The ACC, as we mentioned, score 2. The American guidelines adopt the bold cohort, and the Canadian guideline adopt the Framingham score. The major question here, do we apply this risk calculator to our population? The answer, it might be misleading. It might overestimate or underestimate the risk of the patient, because it's not calibrated to our population. You can use it to discuss with the patient and to show him how the risk factor interact with each other, but you don't trust it because it's not driven from our population and might be misleading. So what to do if the risk calculator is not accurate in our population? We don't have a score to assess the total risk. You'll rely more on the clinical background and the clinical risk factor. And the risk enhancer also can help you to refine the risk of the patient. So for those who has established cardiovascular disease or atherosclerotic, you don't calculate. For those who is diabetic, familial, CKD, they already had a high risk. Apparently healthy, you want to calculate their risk. But what about the very high risk? The very high risk, those who already have established cardiovascular or atherosclerotic, like having MI, and have additional risk factor. These are a very high risk, so this means that you will go aggressive with your target and your treatment and escalate beyond statin. So for apparently healthy, you'll use the risk calculator, and the next step, you'll utilize the risk enhancer. The risk enhancer can help you to refine the SVD risk assessment, especially when the patient in the gray zone, intermediate, borderline risk, you don't know whether to start statin or not. So it can help you to refine your decision. It might be clinical, like CKD, metabolic. It might be female specific, like preeclampsia, GDM. It might be lifestyle, like smoking, etc. And it might be genetic premature heart disease in the family, and biomarker, ApoB, lipoprotein little a, high, mildly elevated, high TG. So it can help you to refine your decision and reclassify the patient. And honestly, this is the tool that we can utilize with our patient. We cannot blindly follow the risk calculator. Also, imaging is another way to help you to stratify the patient and to reclassify him. Like the coronary calcium score, when it is 0, it can help you to defer not to start patient on statin, except when the patient is a smoker, family history, etc. The carotid ultrasound to visualize the plaque, the ankle brachial index also And again, the utility of the imaging, similar to the risk enhancer, when the patient in the gray zone, borderline, you don't know whether to treat the patient or not, this is a helpful tool. When we go beyond lifestyle, when we escalate beyond statin, so this is the lipid target, and if you look at the lipid target, it's coupled with the risk. So we always think of the patient risk and the target depend on the patient risk. The higher the risk, the lower the target that you will go to. It's confusing. There is a lot of number. There is, and it's different from different guidelines. But what we will go with, we'll go with the risk. We'll go with lower target. If we go to the European guidelines, it adopts aggressive target, 50% reduction of the baseline of the patient, and aggressive in addition to target. For those who high risk, below 70, very high 55. Those with recurrent event, even go lower. Don't memorize the number, memorize the risk. Think always of the risk of the patient. What about primary prevention? For those, again, who has no ASVD, he is not one of the high-risk group like the diabetes, this advanced CKD. You want to utilize the risk score. And again, we established that the risk score is not driven from our population, so you cannot blindly adapt it and trust the number that you will get. So you'll utilize it with caution. And this risk score will give you multiple tier, low, moderate, high, very high, and according to that, you will decide whether to start lifestyle or to start treatment. Secondary prevention, those already have the complication. So the issue here is that you'll have to start statin immediately, high potency statin, and think of going beyond, escalating the treatment beyond statin. Don't only satisfy with statin and follow the target. So what is the lipid lowering agent that we have? Statin is still the backbone, still the main treatment to go with, to start with. It reduced the LDL by around 50% and decreased major cardiovascular event. It is safe, there is no significant side effect, but when statin is not enough, where to go? Go to ezetimibe. It is the add-on treatment. It prevents the absorption of cholesterol in the gut, and it reduces the cholesterol or the LDL by 15%. When ezetimibe is not enough, and the patient is still not on the target, you will go to the BCK inhibitor, which is powerful medication, can reduce the LDL up to 60%. And there is a new medication coming, like the inclisiran, which might be a game changer. توقعت بتقول لي الوقت بس. Inclisiran, which is injectable medication, can be taken twice per year, and it might be a game changer. So, statin intolerance. We know that the side effect of statin, the myalgia, the myopathy, the rhabdomyolysis, but the myopathy, the true myopathy and rhabdomyolysis is very rare. And we have to know the nocebo effect. And I think all of you familiar with the concept, might be not familiar with the name, but familiar with the concept. That if the patient expects the side effect, he will get it. And most of our patients, they say that I will have myalgia from, I think this is driven from the media and etc. And they will come to you in a week or 2 or 4 and asking to stop the medication because of the myalgia. The true intolerance is rare, and the nocebo effect is driven by the expectation of the patient, and it's not side effect from the medication itself. So don't stop statin, re-challenge, rotate, go to other statin, like rosuvastatin, lower the dose, alternative day. So don't just stop the statin. When there is a true intolerance, you have other option, which is non-statin. So you'll have a baseline of lipid profile, LFT. You don't need it, a baseline of CK. Unless the patient has any significant side effect, you'll go and test. And think always of the other marker like ApoB, TG, lipoprotein little a. Okay, we cannot test, it's not a variable ApoB, and the lipoprotein little a is still not established at a lab. So what we can use, the non-HDL, which cholesterol minus the HDL, and give you a hint about all atherogenic lipid or lipoprotein, and a simple calculation. What about special population? Like diabetes, CKD, familial causes. So, for diabetes, we established that patients with diabetes, they are high risk. If they have target organ damage, this is very high risk. If they have additional risk factor, and usually diabetic patients have additional risk factor, they are very high risk. So you'll go aggressive with the treatment and think of atherogenic profile. Usually in diabetic patients, the triglyceride is high, the HDL low, and this is atherogenic profile. And LDL might be misleading, might be normal, but still there is atherogenic lipoprotein high or active. What about CKD? Patients with advanced CKD, they are statin mandatory because they are having a high risk. They have similar trend to patients with diabetes, in addition to inflammation, in addition to proteinuria, which is a residual risk even if you control the LDL. What about familial dyslipidemia? When we think of familial dyslipidemia, when you have an LDL above 190, this level, this significant level, it's either genetic or secondary. Usually patient will not have this significant number. If you rule out secondary, this is familial. What is the implication? What is the significance of familial? Imagine that a patient with familial, he has born with a mutation, he has high lipid profile since birth, their chance of having ASVD is 20% or 20-fold, more than general population. And they usually will have ASVD at young age. That's what's called premature heart disease. So they have a mutation, there is a homozygous and there is heterozygous. Heterozygous, high risk, homozygous, the lipid profile will be very high and they have extreme risk. The chance, it's autosomal dominant, so 50% of offspring will carry the disease. Unfortunately, overall data, only 25% with familial are diagnosed and followed and treated. This slide is very important, so I will stay just for 1 minute in this slide. Again, you think of familial when there is very significant LDL, because if you miss one patient with familial, it's like missing the whole family. You have to treat the patient, you have to do screening for their brother, their sister, their children. So if you miss this patient, you miss the whole family. So the concept of cascade screening is to go and screen other family member. So in these patients, statin is not enough. You'll go beyond statin. What about elderly, older patients? There is a cumulative over their lifespan exposure to high lipid profile or high LDL, so they are at high risk. So for those 65 to 75, treat them as high risk. For older population, think of frailty. Frailty is the filter. The life expectancy of the patient might tailor your decision. But don't stop statin, especially in patients with already established complication. You might lower the dose and discuss with the patient. What about female? We established from the prevalence that in our community they have similar profile of dyslipidemia, high chance of being obese, and 1 of 4 similar to male, they are diabetic. So mainly the concept that female at lower risk, and this might be not true. They are at high risk, similar to male, and the risk might be underestimated, and there is female-specific condition that we have to think about it: pregnancy-related hypertension, preeclampsia, GDF. So, for the female side, we are both in the same risk group. The dyslipidemia is not male predominant. So, there is a lot of guidelines. There is the Canadian, the European, the ACC. So, but what's unifying all these guidelines? What is the core of all these guidelines? First, LDL is causal to ASVD. The relationship is not association. It's a cause and effect relationship. The lower the LDL, the lower chance of getting complication. Think of risk. Think of the patient risk. Utilize the other lipoprotein. Utilize at least the non-HDL till we have more data about ApoB, lipoprotein little a, and become part of our lab investigation. Lifestyle is mandatory, adherence, and the treatment of dyslipidemia and SVD start in the primary care with us. And thank you for listening for me.
Now, we welcome Dr. Haifa Al-Hifzi, Family Medicine and Women Health Consultant, Assistant Professor, College of Medicine, King Khalid University, will present approach to chronic pelvic pain in women.
Bismillahirrahmanirrahim. Assalamu alaikum warahmatullahi wabarakatuh. Good morning all. I would like to thank all organizers for the great effort and for hospitality. My topic will be about approach to chronic pelvic pain in women, because there is chronic pelvic pain also in men. And I am labeling my topic as navigating the uncertainties, because you know some patient in some situation, when you just enter your clinic and start to complain of non-specific symptoms, and you know you will deal with uncertainties, like when patient has fatigue, and you know almost all the disease will cause fatigue to the patient, and you need more visits, you need more sitting for the patient, not only for the workup, not only for the management, but in the first place, you need more visits for initial assessment, for history taking, for examination. Because when the patient is complaining of a long-standing symptoms, he will suffer a lot. He will forget in the first place when the symptoms was started and what is the associated symptoms. So you need to remind your patient about all the things related to his pain. So it is a good to know in this topic how to deal with uncertainty by taking this as an example, and also how to be a part of a multidisciplinary care, and how to share your patient in your journey of diagnosing her and managing her complaint. So, and also because we are dealing now with the pain as a disease, not as a symptoms. That's why we are calling it chronic pelvic pain. So it is the name of the disease is related to ongoing pain. So the end symptoms here is the pain. So you will have the biopsychosocial approach, the holistic approach, where you have to not look only for the pathology of this pain, for the cause of this pain, but the consequences of this pain in patient life and the psychological life and social life, emotional and sexual life. So what is the magnitude of this problem? The disability, functional disability is the main problem, and that's why, again, we are stressing on the holistic approach and approaching patient to multiple workup. Some of them will be invasive. It's also raise the magnitude of the problem. I asked the ChatGPT about what is the common clinical scenario of chronic pelvic pain. And the result came with this young female, which is active and complaining of 6-month history of chronic pelvic pain. It was moderate to severe, localized to lower abdomen and pelvis, related sometimes to lower back pain, worsening after prolonged sitting, and maximized during the menstruation. And this is the typical presentation of chronic pelvic pain. Every single word mentioned in the clinical scenario was matching the majority of the presentation of female with chronic pelvic pain. So after extensive workup, including the ultrasound, MRI, to exclude the main cause of chronic pelvic pain in young female, which is endometriosis, it was ruled out. Even the infection was ruled out. So we remained the patient with chronic pelvic pain without known or exact pathology. And then the patient was started on low-dose tricyclic antidepressant with regular follow-up. So this is the common scenario of atypical presentation ended by the diagnosis of chronic pelvic pain. So we have puzzles now to deal with uncertainty, and we have to put it all together just to reach the diagnosis, even if the diagnosis was of exclusion or belonged to pain syndromes. So our puzzles in the presentation, where we have to know, is it really chronic pelvic pain or not? So it will meet the criteria of the chronic pelvic pain. And what are the risk factors I should expect in this patient before going with this diagnosis? And also for the assessment, again, I'm not dealing only with the pain, I'm dealing with the psychosocial consequences of the patient. And I have to know it is primary or secondary in the assessment. It should be. It is the main stone in the assessment of the patient with chronic pelvic syndrome. And then, as the ongoing workup, you will have to include and exclude the pain syndromes and go to different line of management, as we will explain, inshallah. So what are the criteria of chronic pelvic pain? Previously, they label this chronic pelvic pain should be not cyclical, because if it is cyclical, it is associated with menstruation. The pathology has to be here. But with the recent guidelines, the criteria of chronic pelvic pain was a change, because almost the majority of the patient will have this chronic recurrent pain, which is exacerbated by the menstruation. And there is no defined exact pathology for the pelvic organ. So if it is non-cyclical, we need at least 3 months, and if it is cyclical, we need at least 6 months. So what are the risk factors I can expect from in this patient? Genetics. Because you know, or you heard about the pain threshold. Sometimes pain threshold is low in some patients, and this is just because of genetic. They did some research on animal and call it like pain cluster in the family. And in the same person, when he has pain of something, you expect to have the pain from other disease or from other system other than the main complaint. So it is almost genetics, and also the physical trauma. In the researches, they found the sexual abuse was related with high risk of chronic pelvic pain, psychological state as well, endocrine factors. Again, some research suggests that any stress in early life will affect the hypothalamic pituitary gonads axis, which can cause this patient more prone to the pain. And again, any patient with pain will have what we call it central sensitization. So it will be very sensitive, and the pain will be pain threshold will be very low with time. So don't underestimate your patient complaint, because sometimes we call it pain as experience of pain. So once the patient is experienced the pain, maybe next time he will have this pain of flashback of the pain. And also the risk factor, any history of infection or prolonged use of antibiotic can interfere maybe with the flora, with the mechanism of sensitization of the pain in the pelvis. Then the most important thing is to assess the patient for the secondary causes. It was called chronic secondary pelvic pain, but now specific disease-associated pelvic pain. The main 3 diseases associated with secondary chronic pelvic pain, either PID, pelvic inflammatory disease, endometriosis, or irritable bowel syndrome, okay? And for the primary, there is no any secondary causes, so it is the diagnosis of exclusion. And you have to tell the patient to make sure it is really pelvic pain. It's just below the umbilicus and above the inguinal area, so it is defined in this region. And as a part of assessment, you have to assess the quality of life. And there is many assessment tool of that, include the functional, the job, the social relation, the emotional, and the sleep also. You can find multiple tools assist you in the assessment of quality of life. So just we can conclude our approach by this algorithm: history, physical examination, then symptoms. We'll go with which system, just to know where can we find the pathology. My main reference is European Association of Urology, because they have a good guidelines to how to approach to chronic pelvic pain. It was published in 2022, and it covers both the chronic pelvic pain in men and women. First, they put like a mind map. You have like 8 axes. You have to make sure about the region, it is pelvic. Then the system, what are the body system involved in the pelvic region? Then you have to reach to the end organ. And unfortunately, the patient usually have the symptoms of all the system, because it is visceral pain. When the visceral pain is in the place, you have more of referred pain. So you cannot tell the patient will have uterine pain without a referred pain to the lower back, or you have urinary symptoms. So it's almost يعني will you find all the symptoms of all the system, but by the end you have to look for the dominant symptoms. So you can tell it is mostly related to urology, to the bladder, or to the gynecological, or to the pelvic floor muscle. And so referred pain, pain assessment, pain character, associated symptoms, and psychological assessment. And this assessment tool is belong to the International Pelvic Pain Society History and Physical Examination Form. It was also included in the European guideline, and it is very good and comprehensive tool, assess the patient and the physician in reaching the diagnosis and assessment of pain. So you will find like 11 pages. This is in the 2013 version, and the updated version in 2018, it is more extensive and not cited in many articles. So I present this one, the old one, 2013. And here is the time to share your patient and the assessment, because you will give this to home. It's like when you do home monitoring for diabetes, for hypertension. Yes, you give this patient this pain assessment, because the patient will have this recurring pain, and you want, like when you do also headache diary, to know when the pain is started, what was the aggravating, what was the relieving, associated symptoms, psychological assessment. So patients need to have this tool and to review with the patient in the next visit. So when you read this assessment tool, you will find every single detail, even with this figure. The patient can point the place of the pain, and it will help you in the assessment, also in the examination, to know which tender area you will examine. So again, in this guideline, they showed you, as we have in the disease, we subclassify the disease as infectious, inflammatory, malignancy. Also, they help you with some subclassification and phenotyping of chronic pelvic pain, to look for the urology, psychology, organ-specific, infection, neurological, tender muscle, or sexual history. So you will not forget any sub-classification by using this U-point classification. Again, what are the systems we look for in the evaluation of chronic pelvic pain? Mainly, it is gynecological and urological. So the most of the pathologies will belong to these two systems. And then we have the other systems. Of course, when you have gynecological, you will look for all associated regarding the menstruation, gynecological history, signs of infection, and also for the urological, lower urinary tract symptoms. And for the other system, muscular system, when the pelvic floor dysfunction could be the cause. And the patient usually complaining of tender point on pressure, so you can expect any pelvic floor or ligaments in this pelvic area can be affected. And also, if there is any condition, and sometimes it can cause, when there is like varicose vein, can cause this pelvic pain. And digestive system, it's not only the colon, the irritable bowel, even if there is rectal pain, anal pain, we should consider it in the evaluation. And finally, the nervous system is very important. If the patient experiences any signs of neurological deficit, paresthesia, hyperalgesia, you have to include it. And you have to make sure it is related to the pelvis, not to the spine. Because if it is spine, it's not chronic pelvic pain. We have a spine pathology. But if it is only in that area of pelvis and there is no spine pathology, yes, it will be included as a differential diagnosis in the primary chronic pelvic pain. So, then what are the management? Management workup, because it will be continuous. You have to exclude, as we mentioned, infections. It's very important because it is treatable. And inflammation, okay, like when the patient have inflammatory bowel disease, neoplasm, and this is, you have to look for the constitutional symptoms, and spinal pathology. Then you will consider the pain syndrome. What are the most common pain syndrome? Primary bladder pain syndrome, which was known as interstitial cystitis, endometriosis associated pain syndrome. Why we label it as syndrome, while endometriosis is exact diagnosis and we can treat endometriosis as a secondary cause? Because unfortunately, the patient with endometriosis, even when the patient was on proper medication and management, still complaining of pain, not related to the, or not responding to the management. So that's why we included this in pain syndrome. And primary dysmenorrhea, again, why it's primary dysmenorrhea is considered as chronic pelvic pain while it is only cyclic, because of most of patients, when experience this pain, will have in the future the lower threshold of the pain, and you will see this patient complaining of pain even if it's not the time of menstruation. Irritable bowel syndrome, primary pelvic floor muscle pain syndrome, primary coccyx pain syndrome, and chronic post-surgical pain syndrome. Yes, it found in some surgery. The highest percent was in post-bariatric surgery, post-cesarean section, post-hysterectomy. The patient will continue to suffer from the, or develop the chronic pelvic pain. Maybe it is related to adhesions. Maybe it is related to the nerve injury during the operation. Maybe because of the experience of the patient of pain post-surgical, so it will be what we call it central sensitization of the pain. It will continue with the patient after surgery. Okay, just to look for the main syndrome, which is the bladder painful syndrome, or what we call it interstitial cystitis. When to consider it? It is simple. If the pain, we are agree now that you will find the patient with chronic pelvic pain with multiple symptoms, atypical presentation, symptoms that involve all the body system in the pelvic region. But with bladder chronic pain, you will find the pain is worsening when the bladder is full. So it will be the hallmark of the syndrome, okay? And relieved by voiding, but soon returns aggravated by food or drink. And the best of the evidence in this situation to use the amitriptyline to manage this syndrome. Or the other line is to have like Botox injection or cystoscopy with hydrodistension. Okay, so when you find the exact pathology, you will have a good guidelines about how to treat endometriosis with contraceptive pills, with gonadotropin releasing hormone, or even for surgical if the patient has some issue of infertility. And to have psychological treatment, CBT was recommended, and supportive psychotherapy, especially if there is vaginal and vulvar pain syndrome with sexual dysfunction. And for dysmenorrhea, post-surgical and gynecological malignancy can be treated good with analgesia and non-steroidal. And if we have any injury or pelvic organ prolapse, it is best to be managed by surgery. So first, but before to consider any of management, any of pain syndrome, please don't forget to start with the simple approach to exclude the infection, to have the pap smear, to have the high vaginal swab, urine culture and sensitivity, and to consider also if there is a part of inflammatory systemic involvement, like the patient when patient have fibromyalgia and multiple tender point, or the patient has IBS, so you have to consider that. And for the imaging, you will have to consider initially the ultrasound, because it will tell you if there is any local pathology, adenomyosis, fibroid. Some of endometriosis can be seen by transvaginal and